I'm going to give an overview regarding the background and the contents of the ESMO magnitude of clinical benefit scale, and also some of the many ways that it's being used, and also some of the upcoming developments that we're doing with the scale. The picture is of our new cancer center at Charity Cedek, which was opened 3 weeks ago, and it was designed by a Canadian architect. Well, here's the background of the problem. As everyone is aware, we've had a massive explosion of new therapeutic options in cancer, with things really erupting in the last 20 years with the development of different biological and immunotherapeutic options. The major issue with these is the profound cost of these agents. In the dark green, these are drugs that cost between $200,000 to $500,000 a year. These ones are more than $100,000 to $200,000 a year, and that's 69% of the new agents launched between 2017 and 2021. And this poses a major problem insofar as no healthcare system can afford all of these medications. And the economic sustainability demands that we prioritize and make choices, and this requires the ability to sort between high benefit and low benefit treatments. And this comes down to the issue of value. The value of any new treatment is determined by the magnitude of its clinical benefit balanced against its costs. What we know is that the costs of procurement and the out-of-pocket cost to consumers, they vary from country to country. However, the issue of how much benefit the drugs provide, this is a constant. And this is why we have been focusing on this issue, because the other economic variable is one which each country is going to look at depending on their prevailing prevailing resources and their insurance structure. Value decision making is important at an individual level. For patients to ask, is it worth the effort, convenient, risk of adverse effect, and the cost of having to pay out of pocket for a drug, and probably particularly in countries that have public health situations, or national insurance programs, does the marginal improvement in the magnitude of benefit justify the cost of the drug? And because there's going to be a need to prioritize and make decisions of which drugs to fund or not, particularly when there's a limited budget, but multiple new therapeutic options, as we're confronted with each year now, with between 30 to 40 new agents, new approvals coming on the market each year. When I started on this project 10 years ago, in most guidelines, they would make statements about the level of evidence. But the level of evidence would tell you if the evidence was based on a randomized phase 3 study or a meta-analysis, but it gave you no information as to what the magnitude of the clinical benefit was. And in fact, at this stage, there was no standard format for grading of magnitude of benefit. It may or may not have been incorporated into the text of these sort of guidelines, and it was often left to individual interpretation, which was sometimes idiosyncratic and sometimes frankly biased. And in fact, Chris Booth and Ian highlighted this in a paper in a JCO in 2008, when they said that unfortunately the term clinical benefit is sometimes misused to describe the patients enrolled into a trial of either tumor shrinkage or stable disease. So the situation was that there was really no standard measure, and in fact many treatments offering small increments in survival or progression-free survival were being touted as the new standard of care or as breakthroughs. Now, this has consequences. This sort of hype It confounds public policy decision-making. It is harmful to the credibility of oncologists and oncologist research reporting. And indirectly, it could harm patients or cause patient and family distress, particularly when a drug which is being super hyped and then an HTA body decides not to cover it, and patients don't understand why they're not getting this drug, which everyone's saying is so wonderful, it's a major breakthrough. And this was really the trigger case that kicked me off on this was with bevacizumab as first-line treatment for breast cancer. And Lenny Saltz, around the same time, wrote an editorial, "The Progress in Cancer: The Hope, the Hype, and the Gap Between Reality and Perception." Again, highlighting this gap and the lack of having a standard format for describing real clinical benefit. I'll just say a few words about hype, optimism bias, and overstatement. Optimism bias is a pervasive human tendency to evaluate circumstances more optimistically than is objectively justified. And in the oncological world, there are multiple contributing factors to this. We want to promote the perception of professional efficacy, seduction of new technologies, personal investment by researchers or in clinician stockholders, issues related to reciprocity with pharma. Physicians often have selective memory for best responders. They want to promote optimism amongst their patients, and sometimes they're just impressed by the journal that the publication has been published in. That bevacizumab paper in breast cancer was a lead article in the New England Journal of Medicine. Overstatement occurs when benefits are knowingly exaggerated, and this occurs commonly when physicians focused on best outcomes at the expense of really discussing the full range of potential outcomes or likely outcomes, and also often the tendency when discussing a new therapy with patients to trivialize or to minimize identified risks, which are sometimes significant risks. So we identified an evolving number of points of consensus that there was need, or there is need, to improve the value in cancer treatments. That the evaluation of value is predicated on an understanding of what is the magnitude of benefit. That unlike purchasing price and out-of-pocket consumer price, the magnitude of clinical benefit has cross-country relevance. That statements regarding magnitude of benefit are prone to bias and overstatement, and that there is a widespread perception of need for a standard, valid approach to grade likely magnitude of clinical benefit. So this is an expression of the motivation, and when I took this idea to ESMO, it took them 2 years before they agreed actually to take this project on, because initially they were in fear of pushback from pharma. But when they did, they accepted these as the rationales, that there was a need for a well-validated, unbiased approach to the evaluation of magnitude of clinical benefit. That there was a need to generate a disciplined approach to data interpretation to avoid all sorts of idiosyncratic readings of data, and to promote the scientific integrity of ESMO as an organization, and also of oncologists in general, by reducing bias in data interpretation, by reducing hype, and having develop a system of magnitude of clinical benefit evaluation, which is robust with strict adherence to standards for accountability for reasonableness, and I'll come back to this term. And finally, we wanted, for terms of public health use, to provide a reliable and fair evaluation of benefit to assist in resource allocation decisions. Um, so in terms of, this is clearly going to be a public policy tool, and public policy tools need to meet certain standards because decisions regarding prioritization and resource allocations are a matter of substantial social consequence. And thus there is an ethical responsibility to adhere to issues of justice, reasonableness, and having a due process to ensure adherence to the two prior principles. The standard for the development of public policy tools that we have adhered to throughout the development process was described by the bioethicist Norman Daniels from the Harvard School of Public Health. And this is called accountability for reasonableness. This is a process to ensure and maximize the likelihood that decisions or decisional tools are going to be reasonable. And the five issues are that the tool needed to be clinically relevant with reasonable criteria and priorities. It needed to be coherent, widely applicable, have a very robust statistical validity, and a transparent process of development with scope for peer review, appeal, and revision. And as a value scale, we were looking for issues of integrity, and this is again reasonableness, freedom from bias, validity, transparency, particularly with information derived from clinical trials. We need to recognize the limits of precision of the data that we have, and to avoid being excessively dogmatic, to avoid making inaccurate claims of precision. And then finally, the two other things, there's always a balance in a scale between inclusiveness and discernment. You want to robustly credit treatments that may have a true big benefit, but you also want to be discerning and be able to identify those where the benefit is limited. We have had a multi-level development project, and when we started out this project in late 2014, we started out working from drafts from initial work that I'd been doing, and Professor Sobrero from Italy had also been doing work, and we sort of pooled our knowledge together with a group of other clinicians, biostatisticians, and researchers to develop a model. So we had a draft team of researchers, oncologists, biostatisticians, and public health experts. We had consultations from patients, patient representative organizations, and numerous biostatisticians. We did detailed statistical modeling of the tool. Before the initial publication, we went through 13 different drafts, which were field tested across 73 different studies and 13 disease types. And these were repeated until we got to a situation which appeared reasonable to all involved in the development team. And then we had those scores reviewed by outside reviewers to see if they felt that the scores were reasonable, and giving us feedback to make any final adjustments. And in fact, this process, it has been now repeated multiple times. By repeating this process, particularly based on feedback and identifying shortcomings, we then went back and redrafted and made amendments. There have been two versions thus far of the scale. The current one that's being used is version 1.1, and later on I'll discuss some of the things that are going to appear in version 2, which is in the process right now of field testing and being peer reviewed for reasonableness. So in the scale, there are 6 underlying premises. The first premise is that cure takes precedence over the deferral of death. Secondly, that the direct endpoints such as overall survival and improved quality of life take precedence over surrogates such as PFS or response rate. Thirdly, that disease-free survival or event-free survival in a curative disease is a more valid surrogate than progression-free survival is in a non-curative setting, the disease setting. Fourthly, that the interpretation of evidence of benefit derived from surrogates may be influenced by secondary outcome data, particularly toxicity and quality of life. Fifth, that the tail of the curve data can sometimes indicate important gain for a minority of responders. And finally, that data from randomized clinical trials are more credible and more robust than data derived from single-arm studies. Throughout the scale, you'll see reference to what we call the ESMO-MCBS dual rule. And that's to say that you'll see repeatedly for many of the criteria, we're looking at both the relative benefit and absolute benefit together. So we're looking at hazard ratio as well as how much absolute gain there is in progression-free survival or in overall survival. But when we look at relative benefit, we are looking at the lower limit of the 95% confidence interval. So in scoring PFS, we're looking at a lower limit which is less than 0.65, and for overall survival, depending on the median survival of the control arm, whether it's less than 12 months or more than 12 months, it varies slightly. And initially, when we published this, we got a lot of pushback. Why aren't we using the point estimate? And we're not using the point estimate because the point estimate is often conflated with the true hazard ratio, which is an unknown, but which is likely to be within the 95% confidence interval range. This is what the point estimate is. It's often conflated with true hazard ratio, which is an unknown. And so whenever we have speakers in our department and someone says the hazard ratio is, I always make a point of correcting and say that's not the hazard ratio, that's the point estimate of the hazard ratio. You've got no idea exactly what the hazard ratio it is. The point estimate systematically underestimates true benefit in 50% of cases. And giving a precise answer on scoring based on point estimates, which is what the ASCO did with their scale, implies a degree of precision that does not truly exist. And in a large number, we did modeling of over 50,000 study scenarios, looking to see what was going to be the best way to balance our criteria of inclusiveness and discernment. And we found that the best balance was when we used the lower limit of the 95% confidence interval, but also the absolute benefit range as well. And you'll see this repeatedly through the scale. Okay, the scale has 5 forms. In the setting of curative therapies, and this is mainly in the setting of adjuvant therapies, we use a form 1, which are the grade of A, B, and C, where A and B is considered to be substantial benefit. In the setting of non-curative treatments, we have a range of different forms depending on what the primary primary endpoint is. If the primary endpoint is overall survival, then we use form 2A, which ends up being on a 5-point scale, where the highest score is a 5. If the primary endpoint is progression-free survival, the scale is capped, and the highest score you can get is a 4. And if the primary endpoint is neither of these, but it's either response rate or quality of life or a non-inferiority study, then again the highest score one can get is a 4. And finally, we have a form 3 for single-arm studies, and that's also capitated. So the highest scores that one can get in the curative setting are A and B, and a score of 4 or 5 in a non-curative therapy is considered a high score. A score of 1 or 2 is considered a low benefit therapy. I'm going to walk you through some of the forms. This is a form that we use for in the curative setting, primarily with adjuvant therapies. So, if with mature follow-up, or there's more than a 5% in survival, that can cause a grade A. If there is no mature survival data, and the best data we have is disease-free survival, if the hazard ratio is less than 0.65, that can also score an A. At the lower level, if the level of improvement at 3 years is less than 3%, or if the DFS is very small, or if the only evidence of benefit in the adjuvant setting is improved pathological complete remission rate, that scores a C, which is the lowest level on this scale. This is the only form where there is no penalty for toxicity, and that's because the feedback we got from patients was that the patients with curative therapies were prepared to have to put up with a lot of toxicity as a trade-off for cure. But this is unique to this form. Okay. Form 2A is the form that we use in a non-curative setting with an overall survival endpoint. And we have 3 different versions of the form depending on the median survival of the control arm. So there's a version for median survival of less than 12 months, for 12 to 24 months, or for more than 24 months. And you can see in each one, to get the highest score, you want a hazard ratio of less than 0.65. And here, with a median survival of less than 3 months, a gain of more than 3 months. Or alternatively, if there's an increase in 2-year survival of more than 10%. Both of those criteria will get you the highest score. If your hazard ratio is more than 0.7, and the gain is less than 1.5 months, you get a 1. And there's gradations in between. And if you look at the different scales for the different prognostic groups, you'll see the numbers vary. So in this group, with a median survival of more than 24 months, to get the highest score, you want to see a gain in median survival of more than 9 months, or an increase in 5-year survival of more than 10%. So this is the prognostic weighting that is introduced into the scales. Now, based on this element, you get a preliminary score which is going to be between 1 and 4. We ask, does a secondary endpoint show quality of life improvement, or are there statistically significant less grade 3 and 4 significant toxicities that impact on daily well-being? We're not looking for blood counts or alopecia, but we're looking for things like nausea and vomiting, fatigue, diarrhea. And if there's either improvement in quality of life or less toxicity, there's an extra bonus point. And so the maximum score one can get is a 5. In the rare instance that in a non-curative setting that there's a very, very long-term plateauing in the tail, indicating that some patients may be cured, you can also give them a double score based on Form 1 as well. Thus far, we've only had 1 instance of that in the setting of metastatic melanoma. Okay, Form 2B is used in a non-curative setting when the PFS is the endpoint. The top has been taken off the pyramid because the highest score you can get is going to be a 4, and that's because of issues of the lack of predictive reliability of PFS as an endpoint in terms of improved overall survival. Here, again, for different prognostic groups, we have two different versions of the form. If the median PFS is less than 6 months, or the median PFS is more than 6 months, the criteria for the preliminary score are based on hazard ratio and also the gain. But if the hazard ratio is more than 0.65, irrespective of the gain, then it scores only 1. Okay, and that's true for both prognostic groups. So the preliminary scores is between 1 and 3. We asked, did this study have an early stopping rule based on interim analysis of survival? And if a survival advantage was identified leading to early termination of the study, there's going to be a 1 point upgrade. Again, we look at issues of quality of life, side effects, and then based on these issues, we can adjust. When overall overall survival has been a secondary endpoint, and that shows improvement, that will prevail, and scoring can be done using Form 2A. When there is increased toxicity with the new drug, then there's a downgrade of 1 point. If a study shows only improved PFS, there's mature overall survival data shows no survival advantage, and if quality of life was looked at and also doesn't show improvement, so this is a situation of failed surrogacy. The PFS is neither converting to making people live longer or live better, that gets a downgrade of 1 point. If quality of life is improved, there's a 1 point upgrade. And if there's a long-term tail in the curve, with plateauing of the PFS curve, that can also get a 1 point upgrade. So the maximum score, however, is going to be a 4. In studies, in non-inferiority studies, if non-inferiority is established, that in itself does not get credit, because it doesn't mean there's no improvement in clinical benefit. But if non-inferiority is associated with either reduced toxicity or improved quality of life, then you can get actually a high score of 4. Response rate is a very weak is a very weak surrogate for improved survival or quality of life, and the highest score that one can get based on an improvement in response rate is only a 2. And then finally, for single-arm studies, essentially for orphan diseases or where there's high unmet need, the preliminary score is determined by both overall response rate and duration of response. So the highest, to get the highest grade, you wanted to see an overall response rate of more than 60%, or an overall response rate between 20 to 60%, but with a very long duration of response. When the overall response rate is lower and the duration of response is less than 6 months, then you get fairly low grades, and that gives that's a preliminary grading between 1 and 3. And again, if you can show the quality of life has been improved, you can get an upgrade. If there's a lot of toxicity, you get a downgrade, and if there's a confirmatory adequate sized phase 4 experience confirming these findings, that can also get an upgrade. I apologize, it's a very rushed overview of the scale, and on our website we've got very detailed and animated teaching sets to teach how to use each of these forms. The magnitude of clinical benefit scale has been successful beyond our wildest dreams. It's been applied now to more than 300 studies. The two primary papers have been very widely cited. The tool is being increasingly being used by HTA bodies around the world. It's being used in many residency programs in their teaching. The WHO is now using it to assist in the development of its essential medicines list. Some people are using it to benchmark licensing decisions and research design. The patient advocacy groups like it. And industry with industry we have a respectful relationship. This is just an overview of the 340 studies that we've scored. So you can see that we covered a very wide range of oncology over the last 10 years. This is an interesting breakdown of the scores. So what we're seeing is about 30% of studies are getting high scores. About 20% of studies are getting very low scores, with a large number in the middle as well. In an adjuvant setting, we've got a sensitivity problem, and overwhelmingly based on DFS data, studies are scoring very highly, and this is something which we're addressing in the next version of the scale. So in terms of what's new, as I mentioned, the version 2 of the scale is currently in field testing, and it incorporates new approaches to credit DFS as an intermediate endpoint, and that's to say that if overall survival data ultimately show that there was no overall survival benefit, up until now, a score would be 0. And the feedback we got from the patient community was that the time without treatment or disease was valued, and it was valued by them, even if there was no overall benefit in terms of long-term survival. And in the new system, if there's no survival, if there's no long-term survival, the score will be downgraded by 1 point. What we are going to be doing is annotating adjuvant therapies for treatment toxicity. The patients did not want us to penalize them, but they did say they did want the information, and we'll be annotating them for either acute side effects or for persistent side effects like ongoing peripheral neuropathy from oxaliplatin or from taxanes. We will have developed the capacity to score single-arm de-escalation studies in the curative setting. We are updating our criteria for toxicity penalties in non-curative treatments. And we're going to be more stringent on giving credit for tail of the curve, because up until now, you could get credit even when there were very few patients at the time of assessment. And now at the cutoff time, you'll only get credit if at least 20% of the patients on the control arm have reached that period. Oops. The other new thing that's coming along is that we're going to have a dedicated version of the MCBS for hematology. And this has been developed in conjunction with the European Hematology Association. This is now finished its process of field testing and testing for reasonableness, and it's about to be submitted for publication, and we expect this to be out probably towards the end of the year. And so, this opens up until now. The version that we've had up until now has only been validated for solid tumors. This will be validated also for hematological malignancies. We have online animated tutorials which take you through each of the forms as to how to use them with hands-on experience and examples, and these are very clear and very well done, and they're an excellent teaching tool. We were worried about a couple of things in terms of credibility. And we were worried about issues of bias. issues related to exaggeration of benefit or underestimation of harms. And we thought that we didn't want to be just seen giving high scores to studies that were problematic, and so we wanted to have a structured approach to identifying studies that have elements of bias. And this is harmful for multiple reasons. The scientific harm of loss of generalizability, issues of reputational harm for our scale due to loss of credibility. That bias causes direct harm because of misleading expectations, and it can cause societal harm by inappropriate resource allocation for drugs that don't actually deliver as much as they claim to. And to address this, we've done two projects. One, we have developed standards to evaluate how good the quality of life papers are, because there was a lot of concern that much of the quality of life research may not have been as robust as it should be. And we have developed a clinical checklist to identify bias and annotate bias in studies and put these on our score charts when problems are identified. So for the quality of life, we go to make sure that papers have a clear hypothesis, including the chosen method measure, the time points to be assessed, expected direction of change. They must have high compliance rates and a clearly stated and valid approach for dealing with missing data. Results need to have to be as pre-specified methodology, and they will need to be both statistically significant and clinically significant, with a pre-stated minimal clinical difference, and they need to both show that there's statistical benefit, but also that they've crossed the threshold for beyond a minimal clinical threshold. For looking at bias, we have a wonderful paper published led by Michelle Gaiawali, and we've identified design issues, implementation issues, and analysis issues that can all introduce bias into studies. I'm not going to detail these now, so I've actually suggested that I maybe do this as a separate talk for Concilium, but in each of the studies we look at, we're looking at potential sources of bias, and when they exist, as unfortunately they commonly do, particularly with issues of crossover and with inadequate post-progression therapy, this is now annotated on the scorecards. As I mentioned, the scale is being widely used in a range of different uses. I'm going to illustrate some of them. The scores for the 340 studies that we've scored are all freely online as a free resource. This is what this scorecard looks like. It gives the details of the study, the setting, the control arm, the key data, the score, and the reference. And when there are new subsequent publications, such as follow-up data of long-term survival or quality of life papers, the scores will be updated as new data evolves. The scores, the scale is being used widely in a setting of health technology assessment, and we've been using it in Israel over the last 5 years, and we published on our experiences in an editorial last year in ESMO Open, and this has really made the whole process of the Israeli HTA much more transparent. The ESMO-MCBS is incorporated into all of the ESMO guidelines, and in the flowcharts for any recommendation, it shows you what the ESMO-MCBS scores are. So you can see in this setting, the recommendations are all scoring very highly. This is the executive summary of the last update to the WHO essential medicines list, and essentially the threshold now for a drug to become a candidate to go onto the list, that they need to be scoring highly on the ESMO-MCBS, either an A or B in a curative setting, or a 4 or 5 in the non-curative setting. And without meeting those criteria, it's not even a candidate for discussion. We were engaged by Kazakhstan to help them review their national drug formulary, cancer drug formulary, and national protocols, using the ESMO-MCBS and using the ESMO guidelines. And this project really did a total turnaround for their national oncology cancer plan, and not only was able to improve outcomes, but also ultimately reduced overall expenditures as well by taking out a lot of wasteful agents. And this is a scattering of the countries, a map of some of the countries in the world using that have incorporated the ESMO-MCBS as part of their HTA processes: Brazil, Australia, Spain, Portugal, Austria, and Singapore. And the Chinese government are now in the process of translating the ESMO-MCBS to start to use there in terms of their public policy decision making. So I'll conclude with a couple of general comments. Firstly, the no value scale is going to be perfect and would be perfect to generate perfect results in all circumstances. But in order to be widely effective, a scale needs to have specific characteristics of integrity, including reasonableness, freedom from bias, validity, transparency, and a responsive process to valid criticism. A process which involves rigid adherence to accountability for reasonableness, and which recognizes the limits of precision and which avoids inaccurate claims of precision. This is why the scale is only 5 points and not 10 points or 100-point scale. It needs to be inclusive, to robustly credit true big benefits, and to have discernment to avoid overcrediting small benefits. The scale has been impactful beyond anything that we initially imagined. And it's clear now that they are very useful for HTA processes, for the development of guidelines in education, and they are impacting positively on organizational culture. And it's really fascinating to see the impact that it has had on the whole the scientific culture within ESMO. I think it's been excellent for ESMO's organizational integrity. We're working with the London School of Economics, who have looked at the HTA processes of a number of countries, looking at the different variables that influence a positive decision. And by far, the number one factor that influenced decision-making was what the ESMO-MCBS score was. We are increasingly being consulted by industry and by researchers who are looking at what sort of things get credit to help build better study designs. And we are trying to encourage medical journalists to look at this data as well, to improve the quality of medical journalism, to turn down a lot of the hype that we currently see with publications regarding new treatments, some of which really have only minor or marginal benefits. The ESMO website is rich in resources about the ESMO-MCBS in terms of teaching material. All of the papers, the key papers, all of the forms are freely online, as are the scorecards. And when people have queries either about using it or would like to discuss a score, we are our whole feedback system is based on our development program is based on the feedback that we get from end users, be they clinicians, be they researchers, be they industry, or be they patient groups. And and this is how we move this project forward. So that's been a lot to cover in about 40 minutes. I hope I have not been too fast, and I'll now turn off the sharing so I can see you, and I'd really love to hear your questions or feedback. So thank you very much.
Thank you very much, Nathan. So I have tons of questions. So before I completely hijack the floor, does anyone have questions for Nathan? So let me do a show of hands. Andrew, please.
Hi, Nathan. That was just so impressive. I mean, the objectivity and the thought that's gone into it, and the systematic approach to defining incremental therapeutic benefit is just really very impressive. So congratulations, really good. I was just curious, and I'm sorry if this did come up in your presentation, whether you'd got an assessment of the consistency of scoring. If the tools are available to multiple independent groups,
yeah.
What are you finding in terms of the consistency of their conclusions about individual interventions?
Okay, so there's a learning curve in using the scale, and we did initially find that when inexperienced users were using it, they were sometimes generating incorrect scores, and this is why we publish our scores online. So there is a reference score. So one of the things we do in our own department is when my trainees present in journal club, they always need to finish the presentation in going through a study of analyzing what the MCBS score is, and this contextualizes. And so this is a way to teach them. It's a way to teach them how to read and interpret data. And it gives them ultimately then a structured way to help analyze, to give perspective of how much benefit this new treatment is bringing. And so we encourage people. I mean, we wanted to have people to be able to. We wanted to have a tool that anyone can pick up and use. But we do publish official scores, and occasionally a user will pick up on something that we have not. And we will and give us feedback, and we will change our scores. But our scores undergo through a 3-stage vetting before they're published. They're vetted by me, by a second clinical reviewer, and by a statistical team before they get published.
So just question, Nathan. I mean, I absolutely get the fact that if you're using the tool for the first few times, then obviously you are still learning about it, and then eventually, a single user will become more consistent in their own approach. So I was just curious about, for, as it were, maybe mature users, are they broadly reaching the same score?
Oh, absolutely. Yeah, absolutely.
Right.
Absolutely.
Okay.
Yeah. Very much so.
Yeah.
And the other thing is we only score published data, published peer-reviewed data. So abstracts don't get scored. Data that's just been unpublished data does not get scored. Official scores. So we sometimes have the unfortunate scenario where a drug is approved by the EMA or the FDA, particularly by the FDA, before the papers have been published. And we will not issue our score until the peer-reviewed paper is in the public realm.
Sure. Okay. Thank you.
Thank you very much. Any other questions? While everyone is thinking, what was the reaction of the American colleagues at ASCO and just overall in the US? How is this used, or
yes, because because the United States has no HTA process, it is unfortunately less relevant there. It's really more, ASCO, as you know, developed their own value scale, the value framework, and we did a joint project with them, And essentially, what came out of that was that there were multiple statistical flaws in their system, and at this stage, although it is still available online, they're not proceeding in developing it further. The publication looking at the two scales came out in JCO about 2 years ago. And so I think that in terms of robustness, validity, unfortunately, they published it without doing any statistical modeling and without doing field testing for the reasonableness of the scores that were generated. So comes back to this process that we've used of accountability for reasonableness with very careful field testing and testing for reasonableness before we go to publication.
Following up on Andrew's question, for experienced users, how long does it take to grade one study?
Probably less than half an hour.
Okay, very efficient. And another question is, you said that it was tested through 344 trials, but then you gave examples of Kazakhstan or potential HTA agencies. If somebody does it outside your framework, how does this fit in, and how does this cross compare?
Well, they asked us to come in as consultants, and they gave us they wanted us to review their national formulary for oncology. They also had national protocols and to review their protocols, and we found that in their formulary, they had many drugs which were low-value drugs or anachronistic drugs, and many of the protocols we were using were not standard of care, and they were very open to reviewing both their national formulary and reviewing their national protocols to be based upon the ESMO-MCBS scores and also the ESMO guidelines together.
Are those studies that you did for them as a consultant, are they part of those 344 that you stated for testing the tool?
The experience with Kazakhstan was published in ESMO Open. The whole review process we did with them, but the database that we're using, essentially every major trial which has led to the licensing of a new indication over the last 10 years is covered in the 340 studies that we've looked at.
Excellent. So Ian, your question.
Yeah, so Nathan, as usual, congratulations on what you've done. It's fantastic. Obviously, what would really you'd like to see happen is for the registration agencies to start registering new drugs, not on the basis of some p-value, but on the basis of a good score on your scale. And you'd like to see prominent journals, including journals, and probably the worst one is the New England, which will publish anything where the p-value is 0.049 rather than 0.051. And to what extent do you think going forward you could have enough influence, perhaps first with the EMA and with some of the prominent journals, to make those things come about?
I mean, the charter of the EMA and the FDA is to license drugs that are effective and safe, and they unfortunately they are not being chartered to demand that a new drug be better than what's available, and anything which is either equivalent or even marginally better. According to the current charter for both of them, they need to say that this is a marketable agent, and unless their charter is changed, they're going to continue to do that irrespective of what the thresholds are, and thus the burden then shifts to the HTA bodies. Now, America just doesn't have an HTA process at all, and they've got this crazy situation where the Medicare mandate is that Medicare must provide any FDA licensed agent without price negotiation. And then this adversely affects, this has a roll-on effect to the rest of the world. This absolute suspension of market forces in a country that calls itself the most free market country in the world is causing a major economic aberration to the whole drug market. So unfortunately, I don't really have a lot of expectation that it's going to affect the FDA or the EMA. But it is being very impactful at the level of HTA bodies. And we've learned a couple of really interesting things recently from our work with the London School of Economics. For instance, drugs that get accelerated approval, their approval by HTA bodies is likely to be slower than drugs that have a regular approval. And not unsurprisingly, they're less likely to be approved as well. And drugs, we also know that drugs that score highly on the MCBS are more likely to get a more rapid approval. But having a high MCBS score, you can still have a high MCBS score, but if the price is too high, it can still be poor value. And so the cost issues are still a separate challenge that we just don't have. Through this tool alone, we don't have a way of mitigating.
Thank you, Andrew.
Yeah, I just got a couple of questions. The first is just in relation to engagement with HTA agencies to influence their decision making. I wondered if you'd had any interaction with the European Commission as they move towards introducing this unified clinical assessment. And secondly, sort of completely different question is, do you think this tool has application across other disease areas?
So we are consultants to UNETA, and we consult to the EMA, and in fact we've been working on feedback on a new policy statement by the EMA looking at the way they use surrogate outcomes. So what was the second question?
Do you think the tool's got application across other disease areas?
Oh, so okay. So I think the concept. I mean, our tool has been validated so far only in solid tumor oncology. Yeah. In the coming months, it'll be available also for malignant hematology, which is also a lot of agents and a lot of expensive agents, and I think that's going to be very useful there as well. But I think that the concept, and we're starting to work with radiotherapists now to develop a version of the scale for new radiotherapeutic interventions. I think that the particular structure of the scale is based around the endpoints used in oncology, and the endpoints used in other diseases are often going to be disease idiosyncratic and disease specific, but I think that the concept is one which is transportable to other diseases. But I wouldn't do it personally because you need to be adequately expert in the area that you're evaluating.
Yeah. Thanks.
Any other questions?
Hello, can you hear me? Yeah.
Yes.
It was a great talk and wonderful work that you've done. I was just looking at something that's rather older than I thought. It's from Aaron Kesselheim. The most transformative drugs of the past 25 years, a survey of physicians. And it's just a comment, really. It'd be interesting to go back and look at that, which is a very subjective view of the value of drugs. There's a table there with, let me just stop what there is for oncology. It's not a surprise. Imatinib, obviously. But it might be worth you having a look at that paper. It's rather old now, but to come back to Andrew's point, to look at some of the other drugs as well. How things have changed now that you've got this scoring system.
Well, thank you for pointing that out, and I would really like to look at it. There was last year, the year before, there were a group of researchers that published the Desert Island Project, asking oncologists if they were stuck on a desert island, what would be the 20 drugs that they would want available for patients. And interestingly, most of them are old drugs, but of the newer drugs, drugs were Herceptin, imatinib, one of the immunotherapies, either pembrolizumab or nivolumab, and these were all drugs that scored very highly, and I think maybe osimertinib as well.
So there was a good concurrence between the two.
Absolute.
Thank you, Andrew. Last question from you. And
well, it was yeah, thanks. I mean, it's just actually an observation, because Nathan, you said that I mean, one of the things that's happening is that over time people are returning to their original score as new information becomes available about the drugs that they first looked at, and that is going to be interesting, because one of the big challenges from industry has always been that you can't really make solid conclusive decisions about our drugs when they first get introduced, because just isn't enough information, and you're too skeptical, and all will be revealed if only you pay huge sums of money for the next 5 years. And my impression is actually the initial decisions that are taken in very considered ways, using the sort of tool that you've developed, turns out to be remarkably robust over time when you come back to look at it, notwithstanding.
Yes, a small number of scores either go up or down over time. Most scores stay the same.
Most scores stay the same, yeah. Interesting. Yeah.
But companies do not like it when their scores go down.
No.
I mean, I think that Ian will probably chop the Polo study of olaparib in pancreatic cancer. At time of publication scored a 3 because the overall survival data was not mature. But once the mature overall survival data came out, showing we had improved PFS, no improvement in quality of life, no gain in overall survival, it went down to a 2, which was really where it belonged. But no one was arguing back on it. No one was pushing back on us on that.
Nathan, thank you so much. We learned a lot. I'll be in touch with a lot more questions, and we're really looking forward to seeing you back next year with part 2 of the story on biases and trials.
Okay, well,